I'm ready whenever you are.
Awesome. Um, so am I supposed to introduce myself first?
Yeah, I'll
Got
get.
it.
So let's
Uh,
start. Start.
Awesome. So
Hello.
my name's Laura Marks. I'm an infectious diseases physician here at Washington University in St. Louis, and I primarily take care of people who have injection drug use related infections. I have an outpatient clinic that we see patients that, either come to us referred from some of our substance use disorder clinics in the area or some of our needle exchanges, or patients that maybe have been hospitalized for really serious infections like infective endocarditis, and we provide their post-discharge care or things like hepatitis C treatment and HIV care. So that's what I'm primarily interested in and the patient population that I see the most of.
Well, that's definitely a patient population we see a lot of too. Why do you think this is important for us to think about? I mean, can't we just see people, start them on broad spectrum, and then admit them?
Yeah, right. Like Vancomycin cures everything. So I think that this is a really important topic for emergency room physicians because you guys honestly probably see the majority of this population. Unfortunately, there's a lot of people who inject drugs that really have very limited interactions with the rest of the healthcare system. Many may not have a primary care physician. They may not have access to a lot of specialty outpatient care. And unfortunately, their first stop, for good or for bad, for most of their health issues may actually be the emergency department. And you guys are going to see a huge range of infectious complications of injection drug use. And I think it's really important to both think about some of the easy things that we can do to help with the really common sorts of infections that we see, like skin abscesses, as well as also to be aware of some of the weirder and more bizarre things out there that we should sort of keep in the back of our mind on that differential.
Love that. Okay, so before we even talk about infections, but what are things that people often inject into themselves? So, I mean, heroin, we know,
Yes.
but what other things can people inject?
So I think that's a really great question. So we see patients that use all types of drugs. I think some of the most common things to be aware of right now is fentanyl. It's a huge crisis in the emergence in the United States now with this ongoing overdose crisis. So we see a lot of patients that are using fentanyl, but we also see other forms of opioids. So you mentioned heroin, and I think it's really important to split that into two types. So there is black tar heroin or brown heroin that people might use. And then there's also white heroin. And this is important because, as we'll talk about later, there's different types of pathogens that we associate with different infections. And those are based on the way that things are prepared and the way that people inject them. We also see patients that might inject methamphetamines or other stimulants, including cocaine. And then there's the weirder stuff that's injected less commonly, like PCP and all sorts of designer drugs. Those are sort of some of the main drugs that we think about in our patient population.
Great. Okay. So yeah, let's talk about it then. Maybe we can walk through. I'll follow your lead on this, but like, what are some of the infections and complications that we can see from these practices?
Yeah. So I sort of group this into a couple of different categories in my mind when I'm seeing a patient. We have our routine bacterial and fungal infections that someone might have. We also have viral infections that can come from injection drug use. And then we sort of got our group of other weird, wacky things that can happen. So the most common things that we think of, for instance, are skin abscesses. So you can get injection site abscesses, which are most commonly going to be your routine bacterial pathogens. And items number 1 through 50 on there are going to be Staph aureus. So tons and tons and tons of Staph aureus that has to be at the front of our mind whenever we're caring for patients who inject drugs. But we also see all sorts of other pathogens that are going to enter into those abscesses and be really common. We can also see fungi in there, so Candida is pretty common. And then we can see other more unique pathogens that can cause skin infections among people who inject drugs, like mycobacteria. And so a couple of these things will break out based on what the drug is and what the practice is. And we'll talk about that in a moment, but we can think of bacterial pathogens, and then we also think of viruses. So people who inject drugs are at really high risk for a number of different viruses that can be transmitted often through needle sharing or through the shared use of equipment. Doesn't necessarily have to be the needle here. And that's something that many of our patients who inject drugs often forget. So viruses can survive on cookers, viruses can survive on filters. There's all sorts of different steps in the process that these viruses can survive and be passed from one person to the next. So everybody thinks about HIV, which I think is fabulous and really important for that to be at the front of our mind as clinicians. But there's other less common viruses that are actually really important to think of in this patient population. So hepatitis C, huge increase in the number of patients who inject drugs that are coming down with hepatitis C, which is important to think of because it's a curable infection. So whenever I see a patient, even if they're here in the hospital or the emergency room, I always let them know if they do have hepatitis C. And then we want to let them know so that they can get it cured, because there's a ton of people that have been told in the past, you have hep C, but you're not a candidate for treatment. And if they haven't interacted with the healthcare system lately, you might be the first person to say, hey, you have hepatitis C. And by the way, here's the info for the liver clinic or the infectious diseases clinic if you decide to get it treated later. But then the weirder ones to think about, hep B and hep A. So a lot of people, if they're younger, would have been immunized for hepatitis B, but our older patients or patients that maybe didn't get a full vaccine series as kids are at high risk for hepatitis B, and we're seeing that shoot up. But the one that I really want to highlight is hepatitis A, because there are current outbreaks among people who inject drugs. So I'm actually going to do a screen share here, and we can maybe pull it up later. But this is a map from the CDC that shows the current hepatitis A outbreaks in the United States. And the vast majority of these are related to injection drug use. So that's something that's actually really important to think about when you're seeing someone in the emergency department and they're a person who injects drugs and they're coming in and they're feeling not great. Yes, we think about sepsis, but if you're practicing in one of these states with a large hepatitis A outbreak, you're also going to want to sort of keep that on the back of your mind as part of your differential. And it's important to make sure that we're thinking about offering vaccinations to these patients.
Well, I always think about hep A as being a sort of fecal oral route GI disease.
Yeah. And it's not necessarily in this population. And that's something that's really different here. But there was a really great article that came out showing how long hepatitis A can persist on drug use equipment. And the hepatitis A virus can actually survive around 10 days on needles and syringes. So we actually see it linked to the act of injection among people who use drugs. So now that said, there's also a lot of vomiting and diarrhea, and that's going to be a contact that can also promote its transmission, but something that we can still group into this broad category of infections I have to be worried about among people who use drugs.
So when you inject hep A versus, orally ingest hep A, does it present differently, or are they having different symptoms than what I would think of, sort of the gastrointestinal type symptoms?
I don't know the answer to that. There haven't been any reported differences in that, but I also don't know if that's something that people have been specifically asking. What we do know is that there's really high rates of hospitalization among this cohort. So really important to think about if you're in one of those states. And again, those tend to be mainly in the South and Southeast right now, where they're seeing the largest outbreaks. But just here in Missouri, we've had over 600 cases of hepatitis A, the vast majority being among people who inject drugs. So definitely something that, again, not the most common, because the most common are going to be those bacterial and fungal infections that we'll talk about in more detail in a moment. But something that's in the back of my mind is something that I need to be aware of when I'm seeing a patient who injects drugs that's maybe presenting with some nonspecific malaise or abdominal pain or even fever, because it's definitely on the differential there.
Without going too deep into hep A, is there a treatment for hep A? Is this supportive care?
Supportive care.
Okay.
It's going to be the majority of our thing. And also preventative care. And I bring this up because you don't need serologies in order to provide those immunizations. So you can give a dose of the hep A or the combined hep A and B vaccine to someone who maybe you don't have a full immunization history on, especially if you think they're at risk, or if they're coming in with someone else that maybe was infected. And it's a great sort of preventative strategy.
There's no harm in giving a vaccine.
No harm. I think of it like the Tdap. We give out lots of extra tetanus doses, which is awesome because that's also going to be something we're going to bundle in with our weird and wacky. But hepatitis A vaccine, just the same scenario here. If they got an extra dose of the Hep A vaccine in their life, I don't care. I think that's wonderful, especially in the outbreak.
Okay. So we got bacteria. We talked about mostly staph, but then some mycobacterium, maybe some Vibrio in there. I don't know, stuff like that. We talked about funguses with Candida. We talked about viruses, HIV, and the hepatitis.
Yep. Okay. And now let's talk about some other things. So other infections among people who inject drugs, we can also see a higher incidence of sexually transmitted infections. So we see this all the time, I think sort of sex, drugs, and rock and roll, but it's a great cohort to sort of be thinking and making sure that you're doing that screening. So those are sort of broad categories. And now I'd sort of like to move back to the bacterial and fungal because there's a whole host within there. And that's where we see the different types of infections.
Love that. Let's do it.
Awesome. So when you have someone that's coming into the emergency room, the first thing I assume that you're going to want to be deciding is this patient getting admitted or are they going home? And one of the biggest signs that's going to be there for us is fever. And in a person who uses drugs, fever really needs to be a do not pass go. I am going to be super worried about a bunch of really invasive and serious infections. So when I see a fever in someone who has a history of active or recent injection drug use, I worry that not only could this be related to their injection site abscess, sure, that could happen, but I'm a lot more worried that maybe there's now a bloodstream infection or that bloodstream infection has gone on to form metastatic sites of disease. So I think of that as being anything from infective endocarditis to osteoarticular infections like septic arthritis or vertebral osteomyelitis. We see that really commonly, or an epidural abscess, and those have to be on our not missed diagnoses. So fever to me is, especially with that concomitant history of injection drug use, means that they're going to need an inpatient workup because there's a lot of things that we have to rule out that quite frankly are just going to take time for the blood cultures to come back. And now we're talking anywhere from 24 to 48 to 72 hours.
So fevers alone, not just septic presentations, but even just a fever,
exactly.
Everything else looks okay.
Even someone that's normotensive and otherwise looks pretty much okay, if they're febrile and they use injection drugs, I'm worried enough that I want them to be admitted. And most importantly, I want blood cultures. And I think that's really critical. And this is your plea from your ID colleagues.
Yeah,
we love blood cultures.
No surprise there. ID asking for blood cultures.
Especially if there's bad access, why not make it exciting?
Right, exactly. Yeah, okay, all right.
So when we're getting those cultures, a lot of people ask, do I need to send a fungal culture? And my answer here is actually probably no. So I'm actually going to be okay if you just send your 2 sets of blood cultures. And that's because the fungi that we're most concerned about in people who inject drugs is actually Candida, and Candida will grow on your routine blood cultures. So that's one less thing that you have to do. So it's still going to pop up.
Okay. Wow, I didn't know that. Okay, that's great to know. And then, I always wonder, should I be sending 3 blood cultures in these patients concerned for endocarditis? Or...
Yeah. So this, again, it's going to depend on your own institution's policy. I would say at least 2. If you can get that 3rd from separate site, fabulous. We will never say no to it. But at the very least, we want 2. And this actually is going to come back to the pathogens that we're thinking about. A lot of the time, if we're seeing a patient in the hospital and they have a staph epidermidis in their blood culture, we blow it off. I'm like, it's a contaminant. I move on with my life. But in people who inject drugs, there's a much higher incidence of really invasive infections related to a lot of pathogens that we might otherwise think of as contaminants. And so because of that, it actually becomes really important for us to have those multiple blood cultures from separate sites, because that's going to let me decide in 2 to 3 days, they're already out of the emergency department, they're up on the floor. Do I care about that staph epi? Is that what's causing their vertebral osteo? Do I care about these weird bacteria that are in the bloodstream that I normally never think of as pathogens, but this patient has a route of infection that would allow many bugs that don't normally cause infections to get directly into the bloodstream. So 2 to 3 sets of blood cultures, the more the merrier. Fevers that do not pass go must get blood cultures for me. So as we think about those infectious syndromes, this sort of brings me to my physical exam when I'm taking care of these patients and to my HPI, because that's gonna, have some specific and really unique questions for patients who inject drugs that are gonna guide the types of bacteria that I'm thinking about and the types of antibiotics and where I wanna go from there. So the main types of injection-related infections that we see, like I said, infective endocarditis. We see a lot of osteoarticular infections. So lots of septic knees, lots of septic joints, and then lots of vertebral osteomyelitis and associated epidural phlegmon or epidural abscesses or psoas abscesses are going to be really common.
Okay.
So everybody gets a good spine exam when they come in, especially if they have a fever. So when I do that, I like to use the flat of my fist here and just go down someone's spine. If they're uncomfortable, I have a really low threshold for imaging these patients. And I tend not to think of this as someone that is drug seeking, because I don't know about where you practice, but at least where I practice, it is 10 times easier to get fentanyl on the street than it is to get something out of the physicians in the hospital. So if someone has sat there and endured the wait to come see us and they're febrile and they've got point tenderness, I always believe that. And I have a really low threshold to image and make sure that I'm not missing a vertebral osteomyelitis or even an epidural abscess, because those need immediate care.
Okay.
Same thing with my joint exams. So usually when I'm talking, I'm pounding on someone's spine, and then I'm making them sort of move their elbows, arms, touch their knees, touch their ankles. As I'm doing this, we often see a lot of old stigmata from sites where they've injected, and we can also often see areas where they're actively injecting or those sores. And those give us an opportunity to talk about specific practices. And one of the things that I think maybe many of us didn't get taught in medical school was how to take a drug use history. We all got taught the sort of pat phrases for how do we take a sexual history. But I don't know about you, but no one ever really taught me, how do you take a drug use history?
Sure, yeah.
And I think that that's really important for these patients. So when I'm asking specific questions, I'm asking them because I'm thinking about the unique risk factors that patients are exposed to and what potential pathogens those are going to put into my large grab bag of bacterial and fungal infections.
Okay.
So we talked about Staph aureus. That's numbers like 1 through 50 in our pathogens. But we also see a lot of other bacteria. We see a ton of oral anaerobes. We see lots of water-associated pathogens, everything from Pseudomonas to E. coli to environmental Pseudomonads. And then we see a lot of Candida. And then we also see a lot of spore-forming bacteria that you would normally think of as like dirt. I only see these bugs when someone comes in and they've had a penetrating trauma after rolling off the ATV. What is this doing in a 22-year-old that has not been in a car accident? So we see lots of those spore-forming bacteria, particularly our Bacillus species or our Clostridial species. So those are sort of some of the range of pathogens that have to be in the back of my mind. But there's not a great one-size-fits-all antibiotic solution to cover all of those. So I want to ask usually about 3 or 4 key questions so that I can exclude some things and be like, I don't need to cover that. I don't need to cover that. Or it can be like, non-specific answers. Vanc and Cephi sounds fabulous. Or whatever your institution's favorite combo is, Vanc and Piptazo, or
right,
whatever the what have you is.
Yeah, okay.
So the questions that I'm going to be asking are going to focus on a couple of really key steps in the injection drug use process. And these are going to be related to how they dissolve their drugs, and then where their equipment comes from, whether or not it's possible that that was contaminated, what type of drug they're using. So was the drug itself potentially a vehicle for an infection? And then how do they go about the injection process? And is that potentially an entry portal for the infection?
Okay.
Usually when I talk to patients, I try to let them know the why, because I tend to get better and more forthright answers rather than if they just think I'm being super nosy.
Sure. Yeah.
So a couple of the things that we think of, and I'm going to actually share my screen here because I think that this is a great image that we're going to highlight from an article that came out in Open Forums Infectious Diseases. And it's a great image for thinking about those steps and the pathogens. So number one is going to be contaminated needle sharing equipment. So this is your things like your HIV, your hepatitis A, B, C. So those are going to be things that maybe were pre-existing on your injection drug use equipment. So again, HIV always has to be in the back of our mind. And I love institutions that have opt-out HIV screening. I think that that's a really important approach, and it fits in really well here.
So the bacterial ones don't really come from just a dirty needle, generally speaking?
So that's a great question that we're doing more research on. We think probably not, but with one caveat. And the one caveat here is that staph loves to survive on environmental surfaces. So staph is always going to be a risk for any type of used equipment. And in fact, one of the things that I think is really important to do with patients who have an infection is harm reduction counseling so that they know how to prevent these infections in the future. And we always try to tell patients that come in with a staph infection, hey, listen, that infection that you have, it's from staph. It likes to live on everything. When you go home, assume everything is contaminated. You've got to throw out all your old needles and syringes. You got to get fresh ones because they might still have the bacteria on it. Okay. So contaminated injection equipment definitely could have any of the viruses that we think about and any bacteria that like to survive on environmental surfaces. So definitely Staph aureus could fit really well within this category.
Okay.
The next one that we think about is how the drugs were dissolved. So there are different types of drugs that tend to need acidification agents. And one of the most notorious of these would be black tar heroin or brown heroin. And so if you go to a needle exchange program, you'll actually see that they provide little citric acid sachets. And that's not because we want people to have fabulously tasting water, like a spa or something, but it's actually because they want to make sure that they have a sterile agent to dissolve their drugs in. And that's related to the risk of candida that comes from using lemon juice. There have been outbreaks of candida-associated osteomyelitis or other infections that were predominantly linked to people using lemon juice to acidify their brown heroin. So it's something to keep in the back of your mind if you live in an area where that's more prevalent than fentanyl. We don't see that as much here because fentanyl tends to be the drug of choice. And it's basically the only opioid that's on the market in some areas. But if you live in an area where black tar heroin is more prevalent, then that's got to be something that you're thinking about.
So with fentanyl, they don't have to dissolve it, or it's just...
They don't have to dissolve it in citric acid. They are going to need to dissolve it. So I always ask people, do you dissolve your drugs in water? And oftentimes they'll say yes. The next question then is, where do you get your water? Because this is going to let us know how worried do I have to be about gram negatives. So these questions you're thinking about, do I need fungal coverage? Lemon juice needs to trigger fungal coverage in your mind. And then, as well as like someone looking super sick. And then the water question is going to make me think, how worried do I need to be about gram negatives? And we've gotten all sorts of answers from people. Some people try really hard, especially if they've had past infections, to make sure that they're using sterile water or bottled water, which is fabulous. But other people may have less access to safe supplies. Often this happens with people that might be living in encampments or that might have to hide their drug use. And then we'll see everything ranging from tap water to I've had people tell me that they use rainwater, which I guess is puddles, to people that are using the back half of a toilet. All of those are going to run the risk of, really we think about things like E. coli, Pseudomonas, Klebsiella, all of those things that love water. You're going to want gram-negative coverage if you've got someone that's reporting that they dissolve their drugs in an unsterile water source that you're really worried about.
Okay.
So in that case, if they're looking kind of sick, cefapine's a fabulous option for whatever your go-to, generic coverage is at your institution.
Okay.
Now, the other thing that's going to come in here when I think about contaminated agents is contaminated drugs themselves. And this is where things start to get a little bit weird. So normally, we don't think about botulism all that much or tetanus all that much. But these are actually pathogens that can be transmitted in drugs, most notoriously in black tar heroin. So one of the biggest risk factors for tetanus in the United States is actually injection drug use, because Clostridium tetanus, or Clostridium tetani, loves to live in black tar heroin. Same thing with wound botulism. So we definitely can see cases of these. And if you have someone who injects drugs and they come in and they've got maybe a small injection site abscess, and you see them and they're not looking that sick, and then you come back in, a couple of hours later, you getting ready to discharge them, and they're starting to have some ptosis, or maybe some diplopia, or maybe they're starting to have that symmetric descending paralysis. We have to make sure that we have wound botulism on the differential, because we absolutely do see outbreaks of this related to black tar heroin. Wow. And that's also going to be part of how they use the drugs and whether or not they are injecting intravenously versus skin popping. Skin popping is going to place patients at a much higher risk for anaerobes, because all of a sudden we've created a fabulous anaerobic environment. So as I think about how patients are dissolving their drugs and what pathogens that puts them at risk of, I'm also thinking of the way that they're using their drugs. And if they're doing skin popping, then I'm really going to want to make sure that whatever antibiotic regimen I ultimately pick has some sort of anaerobic coverage, because it's a fabulous environment for anaerobes to proliferate in.
Even if they're sort of using bottled water, you're still going to be thinking about that.
Even if they're using all sorts of really safe supplies, if they're skin popping and they now have a deeper seated infection, I'm going to add in some anaerobic coverage.
Right.
So the next two steps that they have here with, dirty or shared agents, this really goes back to the contaminated needle. So they're still thinking about our viruses here. And again, I would add in here Staph aureus or any of those other pathogens that love to survive on surfaces.
And Hep A, I guess, too, right?
Yeah, Hep A too, especially if you live in an area where there's an outbreak. Really important to keep that in the back of your mind. If you live in an area where there's not an outbreak, nothing to worry about. But there are really increasing numbers in those outbreak areas. So keep it in mind.
When we talk about Staph aureus in general, we should probably assume MRSA by default at this point.
I think so, until you've proven it otherwise. Now, if you have someone and you have the luxury of being able to see all of their prior culture results, and they've had 15 different MSSA cultures, it's probably going to be MSSA again. But unfortunately, usually it's only us and ID that get to play Monday morning quarterback, and we get to see all of the lovely culture results before we make a plan. If you're dealing with an undifferentiated patient, you don't have any culture results available to you, until proven otherwise, I would be covering for MRSA.
Okay.
And that brings us really to this question of skin. So
what happened with the filter?
Oh, with the filter, I can't count to 5. So the filter is actually a super esoteric thing that we're not going to worry about too much. Okay. But with cotton, you can get an endotoxin that'll give you a sort of febrile syndrome from Cantonia agglomerans. You don't treat it, you do nothing about it.
Okay.
But that has to be a diagnosis of exclusion. You know, yes, people can have fevers from other causes, but in a person who injects drugs, if they have a fever, I'm worried about active bacterial and fungal pathogens until proven otherwise.
Okay.
The
Wow. I
most
found out about cigarette filters. They contain glass particles.
yeah, bad. Don't do it.
Okay.
And then our next one really is going to be the skin. So we're all covered with bacteria. Unfortunately, many patients aren't going to have access to alcohol swabs or might not have access to clean and safe injecting facilities. And so I do always ask my patients, hey, I want to make sure that I'm not missing a staph or other type of infection. Do you wash your hands and clean your skin before you inject? Now, honestly, even if they tell me yes, I'm going to be covering for staph aureus, but it's a great way to sort of start that conversation about harm reduction counseling and sort of remind patients that, hey, this is usually where these infections come from. The last thing, which I think is really important, is the potential for oral anaerobes. So this is something that a lot of our patients don't know about. You know, patients have heard through multiple sources that I shouldn't share needles because that'll transmit HIV or Hep C. That's usually about where their infectious diseases harm reduction education ends. But if I have someone that's come in for multiple admissions or office visits for infections with oral anaerobes, it's a real shame if they've never heard how that happens. And the way that that usually happens in this population is through the introduction of saliva into the injection process. So I like to ask patients and say, hey, sometimes infections happen from the bacteria that live in the mouth if you use your spit to lubricate your needle before you inject. Does this ever happen with you? Or do you ever do this? And if someone says yes, then I'm going to add on some anaerobic coverage. So this is going to mean that maybe Vancomycin alone isn't probably the best option here. And, you know, maybe I want to add in some metronidazole. Or if someone is going out into the community and maybe they just have a small focal injection site abscess, but they also tell me that, hey, yeah, I do use spit to lubricate my needles to make it go in easier, then they're absolutely getting some augmentin from me. Especially even if I'm covering for MRSA, I might use like doxycycline plus augmentin, or clindamycin is a great option if you don't have a high incidence of MRSA in your area. And some of this is going to depend on your local antibiogram. So for me, for the undifferentiated skin abscess in a person who injects drugs, if they say, no, I use sterile water, I dissolve my drugs on new equipment, I get new cookers, I use clean needles and syringes, then I might just cover for staph. And that might be a patient that to me, depending on my antibiogram, might get anything from doxycycline to trimethoprim sulfamethoxazole or clindamycin, depending again what the local antibiogram looks like. But if I have someone that says, you know, I don't always get to the needle exchange program very regularly, I have to reuse my own needles, and sometimes I use some spit to lubricate them, then they're getting from me something that's going to cover for both staph and oral anaerobes, particularly if they skin pop. And I'm going to make sure that that happens.
And just to remind me, the dirty water using, you know, tap water, rainwater, that's going to make you want to add gram negatives.
Absolutely. That's going to want to make me think, maybe Bactrim is going to be a better option here than, say, straight up linezolid or something like that. Or if I'm really worried that it's an area where we've had a recent Pseudomonas outbreak, I might even think about ciprofloxacin as being an option here. Gotcha. Those are sort of going to direct some of the antibiotics that I'm going to use for a patient going home, or whether they're going to get the generic Vancomycin from me, or if they're going to get admitted on, for instance, if they tell me that they use Candida as part of their solvent process, maybe they're going to get admitted with Vancomycin mica or something like that.
So if we're concerned for Candida, what would we start right off the bat? Is there some empiric thing we would just give?
Yeah, so I love micafungin because that's what we have at our institution. A lot of places have caspofungin. That's fabulous too. So those are great IV antifungals that you can use. If you are a little bit worried, but the patient looks completely fine and you think they can be discharged, then fluconazole is a fabulous oral antifungal option for your patient.
Okay, cool.
And this, to me, usually brings me about to the end of my office visit with a patient, which is, how do we help make sure that this doesn't happen to you again? Or they're getting admitted upstairs, or they're getting discharged out to the street. And I think that this is probably one of the most important parts of that encounter. And I sort of liken this back to patients that might present with a sexually transmitted infection. We often, I think that none of us as physicians would allow a younger patient who was there for their very first time with gonococcal pharyngitis. None of us would say, you have bacterial pharyngitis, I'm going to give you a dose of an IM antibiotic and you're going to be right as rain and go on your way. Most of us would be really clear that, hey, this is actually a sexually transmitted infection. We can absolutely cure this, but it's really important that you know that you can get infections from having oral sex, and this is how you protect yourself in the future. And we would talk about things like condoms or rubber dams or whatever was appropriate for that patient. The same thing has to happen here. A really important part of the conversation with anyone that has an injection-related infection is, how do we make sure that you stay safe in the future and that you reduce your risk of this happening again? And I sort of think of this in a couple of different parts. And the reason that I have this figure up here is because I love the different places that they've thought about ways to reduce the risk during this process. So the very first thing is to think about whether or not the patient wants to continue injecting. In patients that have really bad skin abscesses, particularly those patients that we see where they've got bilateral areas of, really severe infections and scarring, I'll often talk with them about harm reduction approaches to try to give their arms a break. Even if they're not ready to stop for good, we talk about the fact that, that skin needs to heal. So maybe smoking might be a better option for them at this point. Or even, bonus points for this, are you interested in talking with our social worker about getting in at one of the local methadone clinics? Or if you're an ED that does buprenorphine starts, then, hey, do you want to try out Suboxone?
Right.
If they're not interested in that, that's okay. A lot of patients, it takes multiple times counseling. We offer it at every visit, but not everyone is ready to stop. If they're not ready to stop, then we talk about using different sites and how important it is that they don't actually inject into those areas of wounds. And some patients will do that because it's easier absorption, but those wounds aren't going to heal if we continue to inject into those areas.
Right.
The next thing is to make sure, if you have the luxury of having culture results from a prior interaction with the healthcare system, maybe they went to your ED yesterday and the cultures are back now from that abscess that you swabbed. I like to take a pathogen-based approach. So if I see that someone's got lots of oral anaerobes that are coming out of their culture from yesterday or from their last visit to the ED, maybe there's some Eikenella growing in there along with the, staph, all the things that we think about in fight bites or other sorts of dental infections. If I see that, then I'm going to be saying, hey, it looks like most of your infections are coming from spit. We've got to make sure that you're not lubricating your needles with spit because that's where the bacteria are getting in. Or if I see staph all the way through their chart, I'm going to be really emphasizing the importance of making sure that they're not reusing equipment and that if they are, they're cleaning it. And really importantly, that they're washing their hands and cleaning their skin sites before they inject. And then the other weirder or wackier things. If I see Candida, we're going to make sure that we talk about safe dissolution agents. Those citric acid sachets from harm reduction sites or from needle exchange programs are there for a reason. No fruit juice in the injection process. And then the last part of this is going to be making sure that you're aware of outbreaks in your area. So if you're in an area with Hep A and you have someone with an injection site abscess, it's a great opportunity to offer a Hep A vaccine. Or if you're in an area where there's been a recent tetanus outbreak, then we're going to want to make sure that we offer a Tdap because, this is just another type of penetrating trauma that happens to the patient. So tetanus is always going to be something that we're going to want to make sure is up to date in this patient population.
One thing I struggle with some of these viral infections is in the acute infection, your serologies may not yet be positive.
That is absolutely correct, especially with things like HIV or hepatitis C. So HIV is going to be tough here because these patients are always at higher risk for HIV. I tend to think that, our newer fourth generation tests are really pretty good. Unless they tell me that their needle sharing partner has HIV and they have no other evidence of any skin or soft tissue infections, I usually will just go with a fourth generation test and I won't send an HIV viral load. But I don't think anyone is ever going to fault you if you say, listen, this just doesn't feel right to me. I'm going to send an HIV viral load on this patient just to be sure. The only downside with that is it's one of those tests that's going to take a little bit of time to come back. But if we do get that history, it's also a great opportunity to introduce the idea of PrEP.
How about the hepatitis A, B, C, and the Delta agent? Like you would see like transaminitis.
Yeah, so I sort of think of this as being my patient that's coming in with transaminitis. And again, they've got that history that, they don't have any other evidence of a focal site of infection. Maybe they have transaminitis, nauseated, vomiting, they're looking a little jaundiced. I'd be particularly worried, and I might send a hepatitis C RNA or a hepatitis B DNA, or some other form of workup for that acute infection. Or tell them, hey, listen, if you're not feeling better in a couple of days, come back because our tests might not detect this early.
Okay. Great. Yeah, this is super helpful.
A lot of our infections in people who inject drugs really are going to be the more common stuff like Staph aureus. But there's those few questions that you can ask that are going to help make sure that you don't miss something more unusual, that you don't let a case of tetanus slip by you, or that you don't miss that acute case of wound botulism, or that you have the opportunity to look like an absolute rock star to the, infectious diseases team when they come by and see the patient 2 to 3 days later because you were able to ask those 2 to 3 questions.
Amazing. Thank you so much. This is great.
Awesome.